We made a pledge to do what's best for the health of our communities, and we continue to deliver on it every day for every one of our members. With access to a network of over 1 million providers, rewards for living healthy, and more care options than ever, we are CareFirst BlueCross BlueShield, and we are changing healthcare for all that we serve. At CareFirst, it's not just our name, it's our promise.
Good morning, everyone. My name is Ricardo Johnson, and I am proud to serve as the Executive Vice President for Strategic Growth and Government Programs at CareFirst BlueCross BlueShield. And I'll be serving as the moderator for this morning's panel discussion. For over 90 years, CareFirst has proudly served the people and the communities in the DMV as the region's largest healthcare company, serving over 3.5 million people in the region. And as hopefully you saw from a short video that was played, we are deeply committed to the health of our communities. And that's why we're here today. So CareFirst is relentless in our efforts to advance affordable, accessible, and equitable healthcare where all people have the opportunity to live their healthiest lives. CareFirst has been a standing partner to the DC Chamber of Commerce for more than 2 decades. And so it's exciting to say that this is our 3rd year sponsoring the State of DC Health panel for the State of the District and Region Conference. As a company headquartered in the district, we've got thousands of employees here and hundreds of thousands of members throughout the 8 wards. And so we prioritize the health of our neighbors and the communities in the district, which is why I'm excited to facilitate this meaningful discussion and others like it that are being taking place today. As we sit right now, we sit with COVID-19 having created strain on the economics of healthcare. Whether it's from deferred care, the costly treatments that come from the folks that were most impacted by the virus, breaks in the supply chain, the additional costs of vaccinations and testing, and all aspects of healthcare are fluctuating and evolving right now. And so we're asking the question, how do we anticipate the change to come? How do we meet it with solutions? How do we ensure that people across our region can continue to have the opportunities to be as healthy as possible? And so we hope to find answers and have discussions about moving towards solutions in our discussion today. I want to say thank you to the DC Chamber and the extraordinary leadership of Angela Franco and to Board Chair Tanya Kinlow, my friend and former colleague, because none of this work could be possible without the work of the Chamber being dedicated to having these essential conversations with business leaders in our shared community. And now I will introduce with great pleasure the folks who represent a wide level of expertise who are on our panel this morning. First up is Councilmember Christina Henderson. Councilmember Henderson is an at-large member of the Council of the District of Columbia. She also serves as the chair of the Committee on Health. In her previous professional roles, Councilmember Henderson has served as a trusted political advisor to United States senators, DC council members, a variety of state and local officials, and on an array of domestic policy issues that deeply impact children and families. And currently, as a legislator, she's guided by the principle that one zip code should not determine one's opportunity for success. And she is dedicated to advancing a policy agenda focused on equity, education, and reform. And we thank her for being here this morning. We also have Melissa Bird, who is currently the interim director of the Department of Healthcare Finance. And in this role, Ms. Bird serves as the manager of the agency and the chief advocate for annual legislative and agency budget priorities, excuse me. She's also the senior deputy director and Medicaid director, where she serves as the principal manager of the district's Medicaid, CHIP, Alliance, and immigrant children's programs. She has had more than 20 years in health policy and Medicaid and has focused on state level programs and efforts to expand coverage and reform of healthcare systems. And we thank her as well for joining us. Mila Kaufman is with us today. She is the executive director of the DC Health Benefit Exchange Authority and has been since 2012. Really being a driver of the exchange as a public-private partnership responsible for the District of Columbia's Affordable Care Act line of online health insurance marketplace, DC HealthLink. She has a long record of successfully implementing federal and state insurance reforms and revamping and leading government and non-governmental organizations, and is a nationally recognized expert on private health insurance markets throughout the country. Tamara Smith, since 2017, Ms. Smith has served as president and CEO of the DC Primary Care Association, and we know that primary care providers and primary care is incredibly essential to building healthier communities. And the association's mission is exactly that through advocacy and development of the infrastructure to support a high quality, equitable, and integrated healthcare system in the district for every DC resident. Ms. Smith brings 40 years of experience in the healthcare services and nonprofit sectors in the district and in the metropolitan region, serving in multiple C-suite levels in local managed care organizations, hospitals, and human services organizations. And finally, Dr. Greg Agiros is president of MedStar Washington Hospital Center and senior vice president of MedStar Health. And prior to that role was senior vice president for medical affairs and chief medical officer at MedStar's Washington Hospital Center, providing overall clinical leadership and oversight for quality of care and research. And in 2012, he was named a Master of the American College of Physicians, an honor presented to physicians who demonstrate eminence in the practice is an extraordinary accomplishment for physicians throughout the country. And so I am excited, as you noticed from the intros, we have decades of experience on our panel here today in multifaceted ways across government and healthcare. So excited to begin and kick off the discussion for what I know will be a enlightening and robust conversation. And we will have time for questions from the audience as we go through, so jot them down for the end of the panel discussion. So let's jump in. So deservedly, there's been and continues to be a great deal of attention and focus being placed on the district's economic recovery efforts as we are shifting from the COVID-19's pandemic phase to its endemic phase. First question I'll send to Councilmember Henderson. As the district's economic growth and recovery efforts continue, what impact do you think these efforts are having on the city's healthcare delivery system?
Well, good morning, Ricardo. Thank you so much for that question, and thank you to the Chamber for having me this morning. I think we all have some idea of how difficult COVID-19 was for our healthcare workforce and our healthcare delivery system more broadly. And not only that, as soon as we were done dealing with COVID, or as COVID was hitting its endemic phase, we were hit with mpox and RSV and an opioid spike, and now we're heading into flu season. It's just sort of a never ending cycle, it seems as though. But one of the challenges that we're having is certainly dealing with the burnout after all of these quote unquote emergencies kept coming. So staffing shortages is definitely a challenge that we're having. But from an economic perspective, I think one of the things that we're going to have to certainly grapple with is the fact that all of the infusion of additional dollars that we received from the federal government during the public health emergency is now subsiding. And so what do we do to fill in the gaps at the same time that the public is still, some members of the public are still expecting a certain level of care on things? I get daily questions about when are we going to open up the COVID centers again? And I'm like, the money for the COVID centers is gone. And so, how do we kind of deal with that? The economic realities of putting forth a very strong public health approach at the same time that we don't have the same federal funding that we used to have.
That's yeah, it's an incredibly difficult position to be in. Similarly, and I'll direct this one to Melissa. We had Congress established the PHE, the public health emergency, in March of 2020, and along with it came the obligation to keep enrollees in Medicaid from losing their coverage during the pandemic, which allowed national Medicaid growth, including in the district, to swell over the last 3 years. We know that the public health emergency ended, and in April of this year, all DC Medicaid beneficiaries were required to renew their coverage. And so how is the Department of Healthcare Finance provide an overview for us of sort of where the district is in that process, how the Department of Healthcare Finance is working through it, and some of the successes and challenges, as Councilmember Henderson said, the money is sort of running out. There are changes happening in law to sort of move people off of some of the PHE eligibility roles. Can you tell us how that's happening through the district right now, and what challenges we're seeing, what opportunities we have?
Of course, thanks, Ricardo, for the question, and thanks to the Chamber for having me today. From the great thing, kind of one of the shining things from the pandemic is how Medicaid, both locally and nationally, was able to respond and support folks during the pandemic. Having that continuous coverage and making sure folks could access care, just the regular care, but more importantly, COVID testing, vaccination, and treatment. It just showed the flexibility and the really kind of the core mission of the Medicaid program. To your point, Medicaid enrollment in the District of Columbia went from about 250,000 residents to over 300,000 from March 2020 to the beginning of this calendar year. It's a historical high for the program. I've been with DC Medicaid mostly since 2008, and that is by far the highest number of residents we've seen on the program. And then to Councilmember Henderson's point about the federal support is starting to go away for Medicaid. We have something called enhanced FMAP, and that is being phased out this calendar year as we have started the Medicaid renewal process, and at the end of this calendar year we go back to our normal federal support. That's important to note because while we're still going through the renewal process, we're carrying more folks or have more folks in our enrollment, and that costs the district more funds to support that. For Medicaid renewals specifically, what that means is typically when we're not in a public health emergency, residents have to renew their eligibility on an annual basis. That was paused for 3 years, and so starting in April of this year, we started that renewal process for the first time. And so between April of 23 and through May of 24, every resident who's in the Medicaid program here in DC and nationally is going through that renewal process. And then we kind of move into our normal routine annual check after that. For the district right now, we're about halfway through this renewal process. We have over 164,000 beneficiaries who have had their renewal initiated. So simple math, that's a little bit more than 300, a little bit more than half of 300,000. So we are hitting that halfway mark, where I feel like we're seeing some successes. Our renewal rates for our first couple months, we're having about 80% of folks who were in the program, it's like for May and June, pending or already renewed, and that's one of the higher rates across the country. So that's exciting for us, but we're only almost halfway through. And the focus now is really making sure as we have more data and for the folks that we see that are not renewing, what trends are we seeing and how can we change our outreach to those individuals to make sure that that we can help them with their renewal if they're still eligible for Medicaid.
And Melissa, as you get to the latter half of those on Medicaid, are you expecting to see a similar renewal percentage, or do you think it'll go up or down?
Yeah, I can't predict the future. I sure hope so, or I hope it's higher, to be quite honest, because our goal really is for anyone who's eligible, who remains eligible for the program, we want them to stay enrolled. But I will say, month over month, right now, the trends that we're seeing from, beginning of the month and the percentage of folks have renewed to the end of the month it's trending the same way month over month right now. So at this point, I have nothing to suggest that will change. July and August has been a little bit different for us because we've had more folks up for renewal that we had a strong indication that likely would no longer be Medicaid eligible. So we've had a couple high number of months for renewals. But like I said, I hope at minimum it stays where it is if it doesn't get better.
Thank you. So it's a good transition to Mila, as we talk about the integrated healthcare system. Many of the folks in that 20% that are not renewing on a Medicaid will move to some other type of insurance. How are you approaching efforts to ensure the continuity of coverage for private health insurance options for those who no longer qualify for Medicaid?
Well, thanks for your question and CareFirst sponsorship of the panel, and Angela Franco and her leadership at the DC Chamber over these years, and Councilmember Henderson for hosting another Medicaid hearing to keep the spotlight on this issue. So for us, our mantra is get covered, stay covered. Everything we do. And we are working very closely with Director Burt and her team to make sure that as folks are losing their eligibility for Medicaid coverage, they come to us. Unless, of course, they have other coverage. And then we're happy. They don't have to come to us, obviously, if they have another source of coverage. So we're emailing, we're texting, we're calling folks who lost or are losing Medicaid coverage. And we have a special enrollment period. So residents who are no longer eligible for Medicaid can enroll in private health insurance through DC HealthLink. Super easy. DCHealthLink.com is the website. Our coverage is as low as $11 a month, so very affordable. And that's thanks to the Biden administration and the Inflation Reduction Act, which made premiums even more affordable, especially for residents and families at the moderate income levels. So lots of options. And if you lose Medicaid and your employer is covered through us, you can actually enroll through the special enrollment as well into your job-based coverage. And just one last point, a call to action for employers on this at this conference. If you're not offering coverage through us, we ask you to open up a coverage opportunity for your workers who are losing Medicaid coverage, and also help educate your workforce about Medicaid and the importance of responding when Melissa's team reaches out and says, please provide your updated information. So there is a call to action to all employers to help us find people and keep them enrolled or get them enrolled, and help us maintain our 97% coverage rate, which DC now has. We rank number 2 in the nation for the highest insured rate.
Thank you for that, and congratulations. I think it's an extraordinary effort to have 97% coverage for the district's population. And so thank you for your work. If I could take a little bit of a pivot, and let's talk about health equity. The pandemic has had a tremendous impact on the district's healthcare delivery system and exacerbated longstanding disparities based on race, income, zip code, as Councilmember Henderson said. Providers, payers, policymakers in the district are partnering to invest in innovative healthcare payment models that are intended to help to reverse these disparities. If I can start with you, Tamara, and ask you, what role do you think value-based models can play and helping to advance health equity in the district.
Thank you, Ricardo. And again, thank you to the Chamber for hosting the conference and this panel today. First, I want to say one of the things we learned from the pandemic, and I think many individuals have spoken to this, is the importance of collaboration and everyone partnering together to address the challenges that we faced. It was government, it was the private sector, it was the payers, it was the providers, it was community-based organizations. And we learned a lot about the critical nature of working together, number one. We learned a lot about the importance of building those partnerships at the community level. And we learned a lot, thirdly, about the disparities that exist in healthcare. We knew about it, but they became much more highlighted during the pandemic. One of the things that I think is exciting about transformation in the healthcare delivery system to value-based care in particular is because its real theme and focus is moving from touches to actually outcomes. And focusing on outcomes, and those outcomes being people's health status, people's life expectancy, people's access to care, people's utilization of the right level of healthcare. We know people use the emergency department in too much of a great level. They're hospitalized for things that are sensitive to care at the primary care level. And so value-based care's incentive is to change not only the delivery system, the payment system, but the incentive system to care for people in a different way. The incentive for value-based care also, I think, is using population health data. We talked about having a lot of data and learning more now about where are the major problems. We know people of color in wards 8 and ward 7 have higher incidence of death rates and chronic disease and those kinds of things. So we can use data in this whole population health value-based care arena to target folks. And we target folks that are experiencing some of the worst inequities in healthcare. And so I think we can target folks with chronic disease, and the Medicaid office, the managed care organizations, and policymakers have really said, in order to transform, we have to invest. In order to transform, we have to work together. In order to transform, we have to use data. And that data tells us where are the sickest people, what are the sickest people in the communities of the District of Columbia, where are they going for healthcare, and how do we need to intervene? And I think that we can intervene by really looking at trying to redirect people to the right level of care, get them into primary care. We learned a lot in the pandemic as well, the utilization of technology and telehealth and virtual health. We were able to just transform overnight and be able to bring care to people virtually. We also know that people have a preference for sometimes care coming to them. We can't do care delivery in the same ways that we've done it in the past. We need to be innovative. We need to work together. And I think value-based care, because of the change in the payment methodology and in the incentive, gives us an opportunity to be innovative. I think the last thing I would say is that also we need, and we've learned that we've got to address social determinants of health and the social services and needs that people have: housing, nutrition, behavioral health. We now begin to take a whole person look, and it's not just can they get to a doctor, can they get to the hospital, but what are some of these other drivers that are impacting their health and their health status?
That's a great point. And Greg, if I can ask you a similar question, right, from not just from a primary care perspective, but from overall from a value-based care across the hospital's care delivery continuum. How are you thinking? How's MedStar thinking about value-based payment models advancing health equity and social determinants of health?
Yeah, thank you, Ricardo, and thank you to the Chamber for putting this together. I want to amplify many of the things that Tamara spoke about. I'm a firm believer that what gets measured gets managed. And whether you're looking at the reputational analyses, the CMS, hospital compare star rating system, Leapfrog, or you look at the pay for performance measures that are actually involving money, the metrics that are being assessed are the right metrics. It's no fluff. It's no, you're missing the boat. No, these are the metrics that we should be assessed on. And what we are doing and really have been doing with more diligence is drilling into the by race, by gender, by ethnicity results. It's something that we always should have been doing, but we are doing to a much greater degree now. We know early on in COVID that there were reports of outcomes being worse in certain patient populations. And that was the case. I mean, if you look at the patient population at the hospital center, it's about as diverse as you can get. And, where we draw the majority of our patients from, allowed us to analyze, not just the data, but the impact on different treatment regimens. So this is absolutely the right way to look at it. Tamara alluded to, it's not just the volume, it's the results that need to be assessed. She mentioned, and a previous panel member also mentioned, that healthcare is no longer something that you can provide in a silo. It is a team-based sport. And, whether it's, MedStar and the other DC hospitals working very closely with Deputy Mayor Turnage and Melissa's teams, or working with insurers, or working with our partner MedStar Hospitals in Maryland, we must work collaboratively together on this. The continuum of care is the continuum of care, and that involves not just the acute care hospitals, but the SNFs and the subacute rehab facilities, the acute rehab, and importantly, the community-based health aspects of things. We're going to talk a little bit in the future about in a later question about the challenges. When you look at behavioral health as an example, you can't solve the behavioral health challenge in America by just looking at the hospitals. This is something that the community partners that provide care, working with the hospitals and all the other resources that are available in the city, must come together, must be aligned and on the same page for us to be successful. I'm an intensivist, so I rely on data. I love the fact that we are looking at metrics in a very critical way, and are increasingly looking at them by race, by gender, by ethnicity. It's the right thing to do.
Yeah. Thanks for that, Greg. It's before we move away from the topic of health equity, I want to ask Mila to provide a quick update on the ongoing and impactful work that you all are doing at the Health Benefit Exchange Authority's Social Justice and Health Disparities Working Group, and how that ties in to what the providers are doing as it relates to health equity.
Thank you. And I'm so glad Greg mentioned the hospital rates being different during COVID based on race and ethnicity. And we saw that too, and we were shocked when we saw Black and Brown residents being hospitalized and dying at higher rates than white residents. And this was all over the nation, not unique to DC. So that was one of the factors that led us to put together a social justice working group to figure out what we at DC HealthLink can do to be part of the solution, to start addressing the inequity in healthcare and outcomes, the differences in outcomes, what we call health disparities. And so our social justice working group came up with a number of concrete action steps. And I'll talk about a couple of them. One is equity-based benefit design. So we've moved to equity-based benefit design. We've identified conditions that disproportionately impact communities of color. And we know in DC, for example, that twice as many Hispanics report cost as being a barrier to getting care, twice as many Hispanics compared to white residents. And so one way to start addressing cost as a barrier is to eliminate that barrier. So equity-based design for us is we want to make certain care completely free. And so we started with type 2 diabetes. And so if you have type 2 diabetes, you don't have cost sharing, no deductibles, no copays, no co-insurance. So you can get your insulin for free. You can go to your primary care physician for your checkups for free, your eye exam, your foot exam on an annual basis, your blood work, that's all free. Next year, we are decreasing the co-payment for pediatric mental health to $5. And that's also part of our equity-based design. We know, thanks to Tanya Kinlow and Children's Hospital, that we're at risk of losing a whole generation of Black and brown kids. Vicarious trauma, COVID isolation, other factors. So we wanted to do something about that, and we've lowered co-pays to $5. So
Did Mila freeze for all of you? Or is it? Okay.
Psychiatrist, specialist at your patient. That's it, including medication. So that is one big effort that we are currently engaged in. There's also another one that we're paying a whole lot of attention to, and that is racism in clinical guidelines that lead to differences in health outcomes. EGFR, which is a blood test for kidney function, that's been corrected. The national clinical guidelines have been fixed, but not all labs have corrected their testing. Major labs have, many hospital-based labs, independent labs have not. So we have a major campaign on the way to get that addressed. So race is no longer a guarantee for early death or not getting the kidney transplant that you need or getting the wrong dosage, because there's a race adjuster that's still being used. So those are just two examples of our ongoing effort to be part of addressing the systemic racism that contributes and leads to differences in health outcomes depending on race, ethnicity, orientation, gender, and other factors.
Ricardo, this is great. Can I make a point, please?
Yeah, of course, of course.
Sure. So under Jackie Bowen's leadership at the DC Hospital Association, the degree of transparency of the data that we're talking about has increased incredibly over the last 10 years. 5 years ago, the presidents of all the hospitals in the district signed an agreement around transparency of the data. The initial focus was on quality and safety data. 2 years ago, we stood up an EI&D committee. I'm the co-chair of that committee along with Christopher King from Georgetown University. And we are bringing the same transparency to our data around this topic. And we have selected, based on the type of hospital we are, what data we're going to start looking at. And for the acute care hospitals, as an example, we're looking at diabetes readmission rates. For children's, they're looking at asthma readmission rates. And we have similar outcomes that we're looking at for the rehab and the psychiatric hospitals. Again, just another example of no longer do we have however many independent hospitals in the city. We have hospitals that are working together on this, and those outcomes are all being assessed based on race, based on gender, based on ethnic background. Yeah. We have to do this so that we can identify where the best practices are and not recreate the wheel, just get moving in that direction. Thank you.
And I might add, Ricardo, and thank you, Greg, for raising that, because I think Department of Healthcare Finance and CRISP have built a whole population health analytics platform that does very similar things to what Greg mentioned. And it allows us to go in and look at disease-specific categories by payer, by geography, by race and ethnicity. And that's what allows us to go and understand, well, who's been to the emergency department 15 times? Or who's going into the hospital for diabetes when their diabetes should be actually treated at a primary care level? So the data and the transparency and the sharing is an absolutely critical element of our being able to do the work collectively. Thank you.
I wanted to add something that Tamara mentioned earlier through the pandemic and kind of the highlight of telemedicine. And what that really showed to me is that, it just re-emphasized the need to meet people where they are. And so when you start to talk about value-based care and where's that intersection with equity, it really is, when you're talking about value-based care, is putting that person at the center of everything. and responding to their individual needs. And that really gets to the like I said, the intersection with equity, because from my perspective, the kind of, baseline for ensuring that you're moving towards a more equitable health system is that you're listening to the folks that you're trying to serve. So that gets you there. And then to Greg's comment about collaboration, I just want to underline, like, it is, from a payer perspective, it is really, I can easily set up a value-based care payment arrangement, but to make it something that a provider or a system can implement, and it can actually see the outcomes we want to see, that's a whole different ballgame. And from a Medicaid perspective, we have to, be really thoughtful about some of our core Medicaid providers. So obviously it's the clinics, the federal qualified health clinics that Tamara represents, the hospitals for sure, of which Greg's representing, but also our behavioral health providers, our home and community-based services providers that don't always have the same kind of resources and infrastructure to make that move along. Because the other thing that the pandemic showed us too, from another, if you look at folks with behavioral health conditions or certain kinds of disabilities, those are the folks that we didn't have all the things we needed to support them as best we could through a pandemic. And so as we think about value-based care and moving forward, it really is integrating how we bring all those folks along from a payer perspective, and a role that Medicaid has taken on in the past few years is making sure, like, we realize now we really have to provide some assistance to our providers to help make them make these shifts. And also we have to be really aware that when, say in this case, me as Medicaid decides to implement a new payment arrangement, I'm just one payer. Greg and Tamara and the folks and Tamara's members, they have to respond to what Medicare requires. They have to respond to what CareFirst requires, right? So it's also making sure, how do we align from a payer perspective too, so the providers can actually respond and, be able to effectuate what we're looking for.
No, it's a great point, because I think as much as the data is important, as much as the models are important, sometimes you can be overwhelmed with the data, and you've got to figure out, one, how you digest it, and two, to your point, Melissa, but how then can you actually take action on that when you're in potentially 3 different value-based payment models that require 3 different types of quality, or trying to get to different goals, how we can, part of that integration, right, is sort of, in my mind, how you can align payers, Medicaid, Medicare, commercial insurers, around the things that not only from a clinical outcome perspective we care about, but those upstream social drivers that we care about, and begin to focus on the same thing, so that we can at least get the right level of brain attention and focus that hopefully moves to action. This is great. I could healthcare nerd out with you all for a while, but I'll try to keep moderating. So let's switch a bit to talk about money and budget. The district went through a difficult 2024 fiscal year, but budget season, impacted by some of the things, a lot of the things we talked about: expiring federal funding and COVID-19 aid, slower than expected revenue growth, and a lot of competing priorities that are existing in an environment where resources are, there are more people who need resources, and there's less resources to go around. As we move through 2024, and Councilmember Henderson, I'll start with you, since you've got the power in the panel. As we move through 2024, can you just talk a little bit about what budget challenges are anticipated in fiscal year 2025? How will these fiscal challenges, how do you think they're going to impact healthcare delivery, and the commitment to equity that the district has been showing, and the folks on the panels have been showing as we move forward?
Yeah, put the appropriator on the hot seat here. So I think none of this will be a surprise. We are anticipated to see lower than anticipated revenue from commercial property taxes, given what has been happening downtown, with a lot more vacancies, a lot more building owners turning back their keys over to the banks. And then also probably a hit as it pertains to deed and recordation taxes, with just seeing given where interest rates are, far less people in the district are buying homes and far less people are selling homes in the district. We're not seeing the same level of transactions that we saw in the past. But I think there is some potential offset possible from sales tax revenue, because I don't know if any of you have been around downtown, especially in the last 2 weeks. People are here. Conferences are coming back, which is great. Our hotels are seeing customers again, which is also fantastic as well. So we'll see what happens when we get excuse me, when we see the revenue estimates that are coming out here pretty soon. But I think one of our biggest challenges is going to be, again, how do we balance priorities? I've got, it is rare for me to do a meeting where someone is not asking for money. So I like the meetings where nobody is asking for money because it's just really difficult. We have some things that we need to do on the economic side. But I also, I hear from home health aid providers and long-term care providers that, they need more. Our behavioral health providers are also looking for more. We know that we need to increase our capacity to have more providers choosing to serve in the district, as opposed to us having to send our folks to Maryland or Virginia for service as well. So that's just going to be a challenge. And then, of course, we have a looming federal government shutdown, which is going to probably impact our region more than others, where you're going to have furloughed workers. And what does that look like as well? Luckily, from a Medicaid standpoint, we're pretty solid there. But there might be some other grants that are delayed in terms of coming back out.
Thank you very much. And you handled the hot seat very well. Are there other folks on the panel, Melissa, Mila, thoughts on, some of the budget constraints and sort of how that's going to impact some of our healthcare priorities? I called on two people at once. It's a bad moderator. Melissa, do you have any thoughts?
I mean, a general comment just in terms of Medicaid and kind of how it does support the economy in the district and everywhere in every state. We, for every dollar that we locally spend for Medicaid, we're getting $2.33 from the federal government. So it's certainly, I think, a fantastic investment that supports not only, residents getting their care, but as you see through, it goes into the providers' pockets, it goes into folks who are working day in, day out. And then on top of that, it's the core part of it of providing coverage to folks so that they can remain healthy and remain in the workforce. And so for us, it's always, when we look at budgeting, it is our kind of cornerstone is our enrollment. Because if you are eligible, you're entitled to Medicaid. And so it's really looking at, what is our enrollment projection? And as we come through unwinding and going through those renewals for the first time, it's getting a better sense of who will remain on the program and will continue. That will really drive our budgeting process.
And for us, I thought your question was a key question. It's now and every year it's the key question. Does the budget financial pressures change our commitment to health equity? And for us, it doesn't. There are lots of reasons out there we can all identify to stop on this journey that we're all on, and none of them are legit, right? If you're not part of the solution to get to health equity, then you're part of the problem. So whether it's budget or something else, there'll always be a reason not to. And the challenge to all of us is make sure equity and our work towards social justice is always part of what we do.
Great answer. Greg, it seems like you want to jump in.
Yeah, thanks. So from the hospital's perspective, as everyone knows, personnel costs have skyrocketed, and we are as impacted by inflation as everyone else is. Recognizing that on the income side, we're limited. what we get is what we get from the insurance companies, and we know, like many agencies in the district, the DC Medicaid program was impacted by what it took to balance the budget for the district for 2024, and we know that's going to continue to be a challenge for the reasons that Councilmember Henderson mentioned. I think what we need to continue to do is look for alternative payment models. For the last 3 years, that alternative payment model has been CARES and FEMA dollars that have come in. Those no longer exist. And again, through DCHA and Jackie Bowen's leadership, we've been working very closely with Deputy Mayor Turnage and Melissa and their teams around alternative payment models that can help offset any cuts that may have taken place for the FY24 budget. That's going to be necessary for the healthcare system to be able to continue to survive and provide the care to all of our patients that we know they deserve. And that's going to be a critical part of us moving forward.
Right. And Tamara, I'll give you the last word on this if you want to.
Sure, thank you. And I think I'd echo what Greg's saying. I think innovation in payment models and delivery systems will help supplement, some reductions in the funding. I think we learned from the pandemic that it's not just government payers. There's a lot of private sector investment in healthcare in the city. And I think we need the private sector, corporations and businesses and foundations to continue that investment. And particularly as we look at innovative ways to do things, we need everybody at the table. And then lastly, I would say there's a lot of efficiency that we can gain. There's some unnecessary cost that we can reduce. And I think we've got to work together to do that. And I think, when Melissa said, let's put the patient at the center, let's figure out what's best to serve them, and then let's figure out the most cost-effective way to do it. And I think we can take some excess out of the system, and I think we can work together to make sure that we're investing in the infrastructure that we need to really transform healthcare.
Well said. Very well said. Councilmember Henderson, if you don't mind, I'll put you in the hot seat again and just ask if you could talk to us about the rest of 2023. You've moved several key pieces of legislation since the beginning of Council Period 25 and your leadership on the Committee of Health regarding copay accumulators, expanded access to fertility treatment, and most recently the prior auth bill. Can you give us a sneak peek on what we could expect for the remainder of 2023 and as we look into next year?
Yep. Thanks for that, Ricardo. So for those who haven't heard, last week, the committee moved 10 measures out of the committee, 7 nominations for some critical board vacancies that we had for the Board of Medicine, the Board of Physical Therapy, and the Board of Occupational Therapy. We also moved 3 bills, the long-awaited prior authorization reform legislation, which we still have a couple more things to get it over the finish line with colleagues. We also moved an ambulatory surgical facility legislation that, frankly, we have been waiting on since 1985 to get those regulations completed. And then a bill as it relates to the health professional licensing boards and residency requirements. So we're moving right along. We have some hearings coming up, excuse me, in the month of October. The biggest of which probably, well, not the biggest, they're all big and important. I don't want to say one is more important than the other, but we have the confirmation hearing coming up for the new head of DC Health, Dr. Ayanna Bennett. So I hope that individuals have had an opportunity to get to know her since she's been in town. And if you feel so inclined to sign up for that, we have some hearings coming up on some bills that propose some changes to the Medicaid program. So we'll be seeing Melissa at hearings there as well. But let's see, there's a lot going on. There's just a lot of things that are going on. The council just introduced a sense of the council resolution urging the mayor to declare our opioid crisis as a public health emergency. So we'll be holding another hearing on opioids in October as we get off that work off the ground, and then check-ins on some of the things that we've already done. So my first year, we passed the Medicaid expansion for doulas. We want to check in to see how that work is going to make sure that it's working as intended, and same with the postpartum coverage as well. We also will be, we're working on some legislation around some long-term care issues that folks have raised with me since becoming chair of the committee, and more information on that. Let's see. We're waiting on the Health Occupation Revision Act, the HORA, which is supposed to be coming. It's going to be a blockbuster piece of legislation. But, there are just a lot of things going on. And I think also having to deal with whatever the residual impacts of the federal government shutdown is also one of the things. I just had to circulate legislation so that DC can continue to issue marriage licenses, right? Like it's the feds are not of us, but they do impact the work that we're doing and trying to serve district residents each and every day. But I'm really, really excited about the work that we are doing. And I appreciate that, whether it be the Hospital Association, whether it be the Primary Care Association, from Tamara's perspective, just everyone has been really thoughtful and coming to the table with solutions for some of the problems that are facing our healthcare ecosystem.
Thank you very much. Before we go to the last question, I've been trying to pepper in some of what we're getting in the chat from audience questions. Melissa, if I can put you on the hot seat, there's a lot of questions about oral health, and are there any programs or any initiatives to expand access to oral health in Medicaid?
Sure. We currently cover dental benefits for children and some partial dental benefits for adults. And one thing I will stress, a couple of unique factors about Medicaid. One, there's not a special open enrollment period. If you think you're eligible, you apply, and if you're deemed eligible, then you come on into the program, start getting services. The other thing is we don't have premiums or copays, so we try to minimize any roadblocks for folks accessing care, and have what I like to think is a fairly comprehensive benefit package, including the oral health care I just mentioned, but also transportation services and long-term services and supports and things like that. So I hope that answers the question.
I think it does.
I can just
Mila, you got to add on?
Yes, there's no doubt the Medicaid coverage in DC is the gold standard. And if you qualify, that's where you should get your coverage. In terms of dental, if you don't qualify for Medicaid coverage, you can purchase a standalone dental policy through DC HealthLink. You don't have to purchase health insurance through us if you have it somewhere else. If you need dental coverage, you can get it very inexpensively through DC HealthLink, and we have a tool that can actually help you figure out, the best dental plan option for you. And even if you have Medicare, for example, which does not have a robust dental benefit, we have many of our purchasers actually have Medicare and dental through us, as well as folks who work for employers where dental coverage is just not offered.
Hey, Ricardo, I might add something. Federally qualified health centers have a mandate to provide care to all individuals, regardless of their ability to pay. And so, of course, they take Medicaid and commercial and Medicare, but the reality is they have sliding scale fee available for all individuals. And most of them have very comprehensive dental services. They've got hygienists for cleaning, and they have comprehensive dental care. So that's another, I think, access point for folks to access dental that might be a little bit more affordable when they don't have full coverage.
Ricardo, I know dental, who knew this would be so popular? But I just want to throw something out here. So for folks who don't know, we have a great partnership with Howard University in terms of their centers of excellence. And so their College of Dentistry runs full-blown clinics. I've seen them. And I'm proud that DC government has helped to fund some of the refurbishment of the facilities there, but they do everything from pediatric, they have a senior clinic, they do dentures, they do braces, and they have same day emergency walk-in care as well, for anyone who might need it. So I just want to put that plug in
that's
there.
Great. I want this group as my healthcare navigator cabinet. This was that was great. All right, so we've got 5 minutes left. I'd like to just do a bit of a lightning round on this last question and just see from each of you from your seat in the stands and the perspectives that you have with your experience in the district. Can you just talk to us about, what do you think as you look ahead, right, are the critical healthcare system gaps that the district needs to address? And let's set a time limit and say, the next 18 to 24 months. Let's start with Melissa raised her hand.
I'm happy to go, Ricardo, and this will just give me the opportunity to come back to Medicaid renewals. Our tagline now is Act Now, Stay Covered. I do think ensuring folks have coverage. So whether it's Medicaid or through DC Health Link or employer sponsored, all the things that Mila mentioned earlier, as far as allowing special enrollment periods, whether as an employer or the opportunities through DC Health Link over the next year. I mean, coverage is such an important, facet to making sure someone has access to care. And if you have access to care and can take care of your health, the likelihood that you can be, active and thriving in your community is that much more important, or much more likely. So I think, keeping that high level of coverage in the district, we have a strong commitment to it. You can tell with our 97% coverage. I've worked in other states where it's quite the opposite. It shouldn't be considered a luxury. I believe healthcare is a right, but I think that's one thing that we want to keep keep us in that same place with that high level of coverage, so folks have a better chance of accessing care.
Great. Tamara, how about you next?
Sure, thank you. I would echo coverage, number one. I would say, and I think many others on the panel would say, workforce is just a huge issue for all of us. I think workforce from the standpoint of wages, workforce from the standpoint of incentives. The district and the government have loan repayment programs and a variety of other incentives. We need to think about other incentives to get workers here and to keep them here. Safety, I know the prior panel talked about the district and safety, and how are we dealing with safety in healthcare facilities? How are we dealing with safety and violence in community? And how does that impact individuals wanting to come to work in the district and work? And then I think the council member mentioned, facilitating licensure and all those kinds of things, and making it easier for people to get in and get licensed and to work in the District of Columbia. But workforce is, I think, one of the largest challenges we'll face.
Yeah, I agree with that one. Greg?
Yeah, I would echo everything my colleagues have said. I would also add the crisis around maternal and infant mortality. We know that there are a lot of programs that are out there. MedStar Health partners with Mama Toto Village and the Community of Hope to bring care to the patient, as Tamara and Melissa have talked about previously. It's a terrific opportunity, and we're seeing positive outcomes regarding the gap between Caucasian births and non-Caucasian births. However, the playing field is changing. We are seeing an increased number of teen pregnancies. We are seeing more substance abuse in pregnant women, and with the increase in immigration with the citizens that were brought up from Texas to DC, it's not the way it was 3 years ago. So as we continue to initiate these partnerships between the community and the healthcare systems, we can't take our eye off the ball because the challenges are just getting more and more difficult.
Mila, how about you?
And I would agree with everything. I would add, really in the next 12 months, the challenge, if each of us can just identify one thing that we can focus on that will help us to get to more equity, to promote social justice. Just one thing that each of us has the power to change and engage in an intentional, concerted effort to change that, whether it's internal, to examine what processes, what we do now that may have an unintended consequence for some populations we serve, or whether it's how we implement external things. So that's my challenge to each of us and everyone who's watching this. Pick one thing in the next 12 months to change to get us to a more socially just community and city.
Great. And Councilmember Henderson, I feel like I should join your staff. I feel like I just gave you your next session's agenda for the committee. But final words from you. Anything you'd like to add to the list?
Yeah. So, I mean, you gave a timeline, next 12 to 18 months. The biggest for us, we need an on-time delivery of Cedar Hill Regional Medical Center. So from an infrastructure standpoint, we also need to open up that second urgent care center as well, which I think can relieve some of the pressure that we're seeing for some of our hospital emergency rooms on their patient intake and things that are happening there. But also something that's front of mind, sort of echoing Tamara around the workforce issue is like, how do I recruit and get more younger people interested in health type of careers? Right before this panel, I had the firefighters in my office talking about paramedic academies, EMT programs that can be done in high schools. They're thinking too about how do we replenish the workforce as we're heading into a retirement bubble. But talked about this with with the Home Health Association and long-term care folks too, right? We need more CNAs, we need more home health aides. So I think that's something that I'm going to be trying to work with my colleagues on, as well as the school system, around thinking, as we are rethinking high schools already, how do we rethink it in a way that can introduce some careers in a vo-tech way to fill some of these vacancies that we're seeing right here in our city.
Thank you very much. Thank you to all the panelists this morning for taking time out. We have ended on time, so I will stop talking and just say thank you to the DC Chamber of Commerce, and I hope everyone enjoys the rest of the conference and have a great day.